My name is Jennifer. Just a quick note, I'm Jennifer Sanguinet. I'm a director of infection prevention in Las Vegas, hence the pink hair. And I'm here on behalf of Synexis, so my job is to hopefully make sure y'all have a little more information when you leave here about Synexis and the dry hydrogen peroxide technology. So you all heard this morning from Betsy about some of the great work that's being done. And I just wanted to go over a few of those slides. I know a few of these will be duplicates for you, but I really wanted to speak to you more from an infection preventionist to infection preventionist. How many of you are in infection prevention in here? I should see everybody's hands, right? We all have about 1 million things on our task list, one of them primarily being environmental control, right? Making sure that there's no bugs in our hospital. I always tell people, what is my job when I say infection prevention? And my job is to make sure when someone comes in my hospital, they don't go home with something they didn't come in with. So this technology is one of those wonderful things that will help you do that without adding more work. And that's the whole point, right? Because we don't have any more minutes in our day to be spending time doing extra things. So we're going to talk about some of the differences in a few minutes about the different UV technology out there, the dry hydrogen peroxide technology that we have from Synexis, and then also, sorry, I'm getting a little close, and then how we can effectively help you disinfect your environment. This is something that everybody in here, I'm sure, is very familiar with. We know organisms come into our environment. They sit, they hang out. From the United States, in Las Vegas, I can tell you the environment that I'm in, it's very different from one side of Las Vegas to the other side of Las Vegas. I actually originally came from California, and it's very different from one state to the next. And so Betsy is actually from New York, which is even much more different from the California West Coast to East Coast. And when we're talking about the different organisms, the biggest ones that seem to catch people's attention are the multidrug-resistant organisms. And so when we talk about those, it's, you know, we need to be able to say with sure certainty that we're not only taking care of the multi-drug-resistant organisms, which everybody is worried about, those are the ones that hit the news, but also the ones that are not hitting the news. And those are the ones that I worry about more because those are the ones that we aren't testing for. I know in California there's laws for MRSA where we have to test everybody that comes into our hospitals for nasal colonization for MRSA. Unfortunately, the technology available to take care of MRSA is what? It's our environmental services, our housekeeping services that do the cleaning. And Betsy very eloquently shared with you all this morning how inadequate those services are because the moment that somebody touches something in that environment, it's already recolonizing or reinfecting the environment that then will be spread to our next patient via the hands most of the time, or the instruments, or the equipment, or those lovely bed curtains that seem so popular throughout our healthcare systems. So that's really what this slide is about, is just to show you and to remind us all how many different areas are in there that allow the touching. So we're going to move on. So over the years, a number of surface cleaning technologies have been developed, such as the UV technology, which I'm sure you saw out there. Everybody get a chance to go out and talk to the vendors for a minute? We have the air systems, such as HEPA. Everybody's familiar with the HEPA filtration, I'm sure. But there aren't any that really exist that can take care of both, which can take care of the air and take care of the surfaces. And that's exactly what Synexis can do for you. It takes care of both, all right? It takes care of making sure that not only do you have the constant immune system that's available, it's constantly running, you don't have to turn something on, you don't have to have a chemical running, you don't have to have a housekeeper trained, you don't have to have somebody standing there pushing a button, you don't have to close your rooms, which is really important. We've all heard that dreaded word turnover. And as infection preventionists, we all know that we have to turn those rooms over very, very quickly. So in a multi-site study, we're looking at things like, cleaning thoroughness. And I know that Betsy talked about that as well. So when we're going through all of that, you need to make sure that whatever technology you're choosing is covering all those things. So as infection preventionists, we have to be kind of a jack of all trades, so to speak. We have to make sure that we're looking at the throughput. We're looking at how fast the rooms are getting turned over. Is it going to keep our patients out of the rooms? Is it going to keep our staff out of the rooms? Are we going to have extra people to do all those things? Okay. So then we're going to move on to air contamination. And I'm sorry, Denise, can I ask just a question really quick? Can you have them change this so that it moves it back down? Because I can't read the slides. It's too small. So when we're talking about the air contaminants, Betsy did talk about that lovely slide that I think was grossing out our security. I was standing at the back. Our security at the back probably hadn't heard that particular analogy about the flushing toilet and the C. diff, kind of coming up like an explosion out of the toilet, and the fomites. And so it kind of made me laugh a little bit because we're used to, as infection preventionists, sitting there talking about all that while we're eating lunch. It doesn't bother us at all. But for the security staff back there, I think they were turning a little bit green when Betsy was talking about that. But it's important for us to understand that, everything that we do within that room needs to be touched. And the UV, unfortunately, one of the things that's troublesome with that is about shadows. With the HEPA filtration, it's not as great because it's not necessarily disinfecting the air, it's just pulling the air through a filter system. So we have to talk about all of those things with our administration, and I know that we all get inundated daily. How many phone calls do we get from vendors every day? How many, people do you have to say, I'm sorry, I can't talk to you right now? I have, 5 other, not even 5, probably 5,000 other things that are on this list for me to do today, outside of talking to a vendor about a particular technology. And then we do mention, obviously, the SSI. In our, SSIs are huge. And I know Betsy mentioned the implants, such as the hips. But I also think about our other clean procedures, such as the abdominal hysterectomies. I think about the moms. I think about the hips, the knees, all of those clean procedures. And I know that in my career, and I've been doing infection prevention for probably 20 plus years, and in my career, there have been times when I've just shook my head and said, how did this person get an SSI? It's a healthy individual that came through this surgery. There wasn't anything that they got exposed to. It was for instance, I had a patient who came in and came from an outpatient situation. And in the US, we do have a process that's it's called nose to toes that was implemented at one of my facilities. And we did all of the decolonization because we were worried about Staph aureus. And so the patient came in, we did all of what we were supposed to do. And when the patient was finished with their surgery, they were taken up to our inpatient floor. They were in a room by themselves on what we called clean floor, meaning there was not any patients in the last month or two that had had any contact isolation. And somehow, some way, this patient ended up with an HAI SSI. And unfortunately, we struggled to figure out how. And those are the situations that I'm sure as infection preventionists you all struggle with every day, figuring out how, where does it come from? Another situation I'll share with you was in a burn center. I worked in a very famous burn center for quite some time in the beginning of my career, and we had a situation where we could not get rid of MRSA. And it was a MRSA that obviously we all know that's spread by contact. And it speaks to this as well when we're talking about SSIs, because if you think about burn patients are probably one of the most immunocompromised patients I can think of, because they have one of the least abilities to protect themselves, they have the skin missing, which is the first initial barrier, right, to protect yourselves. And it was probably 11 months of time working on that we had patient after patient that got MRSA. And unfortunately, the MRSA actually was eating the grafts. And I speak that wholeheartedly because obviously burn patients aren't just adults. Burn patients are from little tiny, tiny ones to full-grown adults, to elderly patients. And they've already had such tragedy in their lives, and then you're seeing that happen. So when I speak about this technology, I truly speak from the heart, and especially with the SSI, because you're talking about patients, and I know that we all do this because it's about patients first. And, you know, we talk about the clean procedures. And I know Betsy mentioned this, and when we say that it only takes a very minute amount, when you talk about MRSA, it takes even less. And the particular strain that was causing this big, huge outbreak in our facility was the Brazilian strain. And if you have a moment, I would encourage you to go look that up, the Brazilian MRSA strain. It was very big in the U.S., and it actually was only in New York and then only in California. And it ended up getting to the point where we had our nurses segregated to the patients. We tested every nurse, every healthcare worker, every person who was in there, every doctor, every surgeon, everybody. We went through, it was a very long procedure, I say procedure, but a very long trial to get through that. And we finally got to the point where we had to completely close down the department, kept it closed for about a week, and got everybody out. And once we got everybody out and then reopened, guess what? It went away. Why? Because it's spread by contact. We know that. Had we had something like this technology, it probably wouldn't have been happening, because we do know that this technology is something that would have saved us, so to speak. Betsy already spoke to you all about if you were here this morning, about the airflow pattern. I think of this picture kind of makes me chuckle a little bit, because it's supposed to be representing the laminar flow. It's supposed to represent the fact that it's pushing everything down to the floor. It looks like something else kind of gross to me, but it's supposed to be looking, the laminar flow pushing everything down to the floor and out. But if you think about it, if there's something up in your ventilation system or there's something up at the top, what is that doing? It's pushing everything right on top of your OR surface. Or if something isn't cleaned properly, or how do you know that the top of the OR lights are being cleaned all the time properly? Have you all gone in and looked at the top of the OR lights where the doctors reach and touch? I know I have, and there have been times when I've seen fingerprints. So nothing's perfect. This one is a personal one to me now. This is about the compounding pharmacies, and we have a situation in Sunrise, which is a good thing. Sunrise is going through an expansion right now, and we are right now 690 beds, and they are building a whole new tower. And the new tower, unfortunately, has its own battles to win, because what happens in Vegas doesn't just stay in Vegas, no. What happens in Vegas is it's all sand and it's all dirt. So what happens is when they drill into the ground, everything comes up, everything fluffs up. Well, unfortunately, where the tower is, it wasn't really thought out too much, because that's where the pharmacy is. It's right across from where the pharmacy intake air is. And so the building that is there is where the pharmacy is. Some of that ventilation and some of that building parts are the original parts. And we're talking from we just celebrated our 60th anniversary in that building. So it's pretty old. And we noticed that, we got help noticing that when we did our air testing, I'm sure you all do that here, you do air testing in your pharmacies to make sure that the air is proper in the clean rooms and in the chemo rooms. And when we did our testing, it came back that it was not where it needed to be. Oh no, we had stuff in there that wasn't supposed to be in there. Go figure, all of this stuff being dumped on top of the pharmacy intake, right? And then it got overwhelmed very quickly. Well, I came from California. I'd only been at this hospital probably a little over a year, and didn't realize that the ventilation system was the same age as the building. Good way to find out, right? So I get this frantic message from, it's been like the third pharmacy director, saying, oh my gosh, we've got these positive results, what do we do, what do we do? And my first response was, okay, we stopped doing the compounding for the time being. We need to figure out something. Fortunately, my corporation has 2 other facilities within Las Vegas that could do the compounding, so no worries. We're okay there. However, what are we going to do? Because we can't shut down the pharmacy. So we said, well, what can we do? And HEPA filtration wasn't fixing the problem. We had already gone up there. We'd already changed out the filters, already gone through all of that. So what we did was, I'd already had a relationship with Synexis, and I asked them, I said, could we get because they do have mobile units, could we get one of the mobile units and get it brought over here quickly, or get it sent to us quickly? Because I knew that what was in the air was actually fungus. Because our building's old. You guys don't have any problems with fungus here, right? None? Zero? Zippo, right? I mean, because it's a dry climate here, right? So we had some fungus among us, and we had to get that out of there very, very quickly, because it was in our chemo room, which is probably the worst place you can have it. And we got it in there, we turned it on, which is what was really nice about this particular technology. The mobile units especially, you can just put them in there. It's like a plug and play. You plug it in, you turn it on. And it was a couple of days. I think it was like 5 to 7 days. They retested again, and it was gone. And so what our HEPA filtration couldn't do, that could do. And then the other issue that I also had tried at the same time was our sister hospital does have the UV technology. They have the robots. They have the, I believe it's the Synexis. And our issue was that they didn't have someone who could come with the robot to bring it over there. But what was the second issue? What do you have to have in order to use the UV technology? You have to shut down the area, because we have windows. You can't. It's not like you can have somebody standing there watching it. We'd have to completely shut it down. We can't shut down. We needed something in there that could be going at the same time while we were still working. So that's what happened with our chemo room, and fortunately it's back up and functioning now, and we've left them there because the pharmacy is much happier, the air is much cleaner, and the people are happy. So in trying to reduce the microbial threats, there are obviously a number of challenges. We have to look at the viruses, we have to look at the bacteria, we have to look at the fungi, we have to make sure that we have people who are trained. If it's particular technology, you have to make sure that it's safe. You have to make sure that there's no chemicals depending on the patient population. You have to make sure that it's not going to harm your patients. You have to make sure it's going to work on the surfaces, that it's not going to be in a shadow, that it's not going to be, it's going to get under the boards, it's going to get everywhere that it needs to be. So, guess what? This technology answers all of that for you. So, I'm going to do this pretty quick for you. I don't want to get into all the super technology, because we do have some literature available that you can take back with you. But the high-level overview is that the technology uses the humidity or the water. It breaks it apart, and it puts it back together as a gas form of 5 to 25 parts per billion of dry hydrogen peroxide. And what that means is that Synexis owns the gas patent of dry hydrogen peroxide. They are the only ones that own that, okay? I know there's other technologies out there. I know it's confusing sometimes, but some of the information that's out there, there's other technologies, and it's different types of technologies, so we need to be really cautious. But that's why I chose to be testing this. The pharmacy part was not a test. The pharmacy was, we put it in there, we did it, we didn't even test it, because my administration believed and went through the literature and knew that it was a safe thing. They spoke to the folks at Synexis and said, yes, we know this is safe, we're gonna do this in the pharmacy, not a problem. but we're doing some other things right now that I'll get into in a minute at Synexis, or at Sunrise. But DHP is specifically designed to disinfect the air and the surfaces, and they are the only ones that do both. And they do it in a manner that's safe both to the staff and the patients. You can be in there. It doesn't require someone else to be standing there. It doesn't require an operator. It's passive. And most importantly, it doesn't require infection prevention to do a thing. And that's what was really happy for me, because I'm thinking through this going, oh my goodness, I don't have to worry about where are the machines? Are they doing the isolation rooms? Are they not doing the isolation rooms? Is it being done correctly? Do I have to audit? Do I have, all of those things that we normally worry about as infection preventionists? With this technology, you really don't have to, because it's automatic. It's there. It's effective against insects. This was really exciting to me too. I don't know if you have this problem here, but in America, we have problems, especially in Vegas, believe it or not. I'm gonna ruin it for you if y'all love Vegas, but we have problems with bed bugs. And unfortunately, especially with the population that comes into my hospital, and I'll be very straight with you. We jokingly, semi-jokingly, my hospital is 3186 Maryland Parkway, okay? So our population that comes into my hospital, 30% of our population uses that address as their home address, which is kind of sad. And what that means is about 30% of the population is homeless, okay? So that's a very large population that is exposing, coming into our hospital, into our waiting rooms, into our patient rooms with bed bugs, with scabies, with lice, right? Roaches. I'm sorry if I'm ruining everybody's morning. It's gross, but it is what it is, right? We deal with it every day. This technology actually kills all of that, all right? It takes care of it all. It's designed to go anywhere the air goes. Wow, right? It goes into the walls and the crevices where the cockroaches love to hide. It goes into the beds. It goes under the beds, all those places the bed bugs love to hang out. So it goes everywhere. So I'm sure you all are thinking right now, well, is it really too good to be true? We talk about the safety. I've talked about the safety with you for a few minutes. This really just talks about the efficacy and the safety of DHP. We want to talk about, because people, when you hear the word peroxide, it's scary, because peroxide is very corrosive. However, in this form, it's not, and I can tell you that from my own experience. My pharmacy staff, probably they would accost me if I went and took their little mobile unit, and it's about the size of a computer, the one that's the mobile unit right now that's on wheels. They would probably accost me if I went and took it away from them. And it's sitting, the one that we have is sitting in the chemo room, and there's another one that we actually, which we really don't need, but it makes them feel better, so we gave them two. But there's one sitting in our anteroom that goes, because we have this really weird setup in our pharmacy that you go through an anteroom to go into two different rooms. So they wanted both. I don't know why this keeps going backwards. Sorry about that. So when you talk about the safety, this is really what this slide talks to. 2.5 years to reach the concentration of 1 drop of hydrogen peroxide. 1 drop. So I'm talking about that cabinet in the brown bottle. Well, we have brown in America. I'm not sure. What color is yours here? Brown? Is it brown? So the brown bottle of hydrogen peroxide, 1 drop of that, 2.5 years it would take the same of the gas form to get there. Okay, that's a heck of a long time. And that's if it was all concentrated at the same time, kept all in the same room, and never let out, and there was no leaks nowhere, ever, ever, ever. So this really talks to you about the science part of it. So for those of you who are not science geeks, which I am not, I'm going to make this pretty simple. So when you're talking about the aqueous solutions, the hydrogen peroxide molecules, they're always competing, okay? It's competing with the water. So you have the hydrogen peroxide coming down, and I'll go back one, sorry. So you have the hydrogen peroxide coming down, and it's trying to get along that bottom row at the same places, right? If you have water there, what's happening? It doesn't have anywhere to park. Y'all understand the parking analogy, right? I get it here. By the way, driving on the wrong side of the road still scares the heck out of me, and I've been here for 4 days. To me, it's the wrong side of the road. To you guys, it's the right side of the road. So 1% aqueous hydrogen peroxide mix, 1 molecule, hydrogen peroxide has to compete with 95 water molecules. So there's 96 people. There's only 1 parking space. Okay. Go for it, right? But then when you're talking about the dry hydrogen peroxide, however, guess what? There's no competition because it's not having to compete with the water. There's nothing to compete with. So it automatically will continue to work all the time because there's nothing for it to go against. It's always going to be there. So we've talked about the safety and efficacy. It's safe. It meets your regulatory requirements. This reiterates a lot of what we've already said about the safety and efficacy. But I think some of the concerns sometimes is that it's a vapor. It's not a vapor. It's a gas. You wouldn't even know if you were standing there that it was going. One of the things that people notice, or that we've been told that they notice, is the lack of smell. Who's ever smelled C. diff? I have. It's a funky odor. Okay. And that's one of the things you won't smell, or at least smell less of, because it's continuously working. It's a continuous ongoing immune system for your environment. The other thing that it does is it continuously works on soft fabrics. So those curtains that are sitting there that are always gross, that we know they're gross, but who has the time to change them for every single patient? They're always working on those too. So DHP is mimicking the natural process in our bodies. It's using the ambient water and the oxygen to create the dry hydrogen peroxide. That's the elevator speech. This one gives you the comparison of all the technologies. And again, I'm not saying that anything is necessarily bad. They are. There are reasons for other technologies. However, if you want something that's continuously available, that doesn't require anybody extra to do any extra work, doesn't require you to do anything more than change a sail within the machine, and actually that's something that, right now is the company takes care of. So, and it's every, 4 months, 3 months? So that's, for the other stuff, unfortunately, for the UV technology and things like that, you do have to have someone that knows how to do it safely. And this one talks about the log reduction. So this is for my science folks. So DHP does the 3 to 5 reduction. It's better than, can say that it's a 3 to 5 reduction is better than the 10 log of the other ones because it's all the time. It's not like it gets it down, it drops it down to something, and then it'll go back up because you're taking it away, right? So we know that the UV systems, or some of the other systems, I'm not just saying UV, but some of the other systems, you take them in there, you turn them on, it's working, it takes it down. The DHP, however, because it's continuous, it's always running, it takes it down, a 3 to 5 log reduction, but it keeps it there. It's continuous. So it will always keep it down at that 3 to 5 log reduction. So it's always chasing 0. All right, so this one's talking about, there was a trial that was swabbing the metal filter of a water faucet. And this one is about mold and some other things. And you can actually see, again, the very high reduction. This one is from an outpatient cath lab. And this one was the Pima Heart in Arizona. And they did a doctor's office in the recovery in the nuke room. And over on the right is in the procedure room. And again, it's a very high percent reduction. And it gets it down there again, it gets it down there, and it keeps it down there. It's not like it goes up and it goes down. It keeps it down there. This one was for a wound care center in Arkansas. And again, you can see once it starts at the top, it gets it down the percentage. And this one I like because it's the different hours of the day, and you can see where it bumps up a little bit. And the time it bumps up was around hour 2, a little bit. But it goes down again around hour 3. The hour 2 was around 9 a.m. What happens around 9 a.m., especially in like a wound care center? When are all the patients showing up? Around 9 a.m., 8 to 9 a.m. So around 8 and 9 a.m. is when all the patient population, so there's a lot more patients in there. So of course you're going to see more microbes coming into the environment, which means the system has to continuously work. It's still continuously working. So you're going to see that little bump up, but then again it starts to drift back down because it is working continuously to bring it back down to 0. And then this one is, this is the surface. This one was in a long-term care facility. Do we have any long-term care facility folks? Great, so this one would speak to you a little bit. And again, this is talking about the contamination CFU over time. And you can see over on the left-hand side, so long-term care folks, you know your patients are there a long time, hence the term long-term care. They're there a long time. So their environments tend to be probably overgrown, so to speak. And so you see there on the left, the numbers are very, very high, and then over on the right, 2, 3, and 4, it goes down and it stays, but it bumps up and then it bumps down again. It does kind of the same thing. But it's continuously, it drops it, and then it goes up and goes down a little bit. The increase at month 3 was actually, and these ones, by the way, are by months. So the increase at month 3, guess what month that was? Anybody guess? When do long-term care facilities get the most visitors? Christmas, that was December. Go figure, right? So there was a whole bunch of visitors. That was December. And so they got visiting family members residing at Elliott. This is that long-term care facility. So they had a lot of visitors. And then by January, it came back down again. So it had to work much harder. The numbers obviously went up some. Okay. And then again, Elliott, long-term care. And then this is the one that we're doing right now, and I'll be really quick and brief because we are in the process of this. This is our Multicenter Study. Sunrise is a multi-center. We have a children's hospital. We have an adult hospital. We are soon to have a burnout patient and a burn-in patient. But we are testing it in all of these different areas, pediatrics, intensive care, cardiovascular, because we really do want the data for folks like me and like you to be able to take to our C-suite, to be able to say, here's the proof so that we can get it in for our folks. And then the Veterans Affairs Study, they're doing something in a community living center. And again, it's a grant. This one is a grant from the Agency for Research and Health Quality, and it's a large study for high-touch surfaces. And then there's a lot of stuff in here about multi-drug-resistant organisms, and I just want to mention very briefly multi-drug-resistant organisms. One of the things that's big in the U.S. that's come up is the Candida aureus, but Synexis quickly addressed it and has the proof here. So as the new bugs emerge, as long as they have similar properties, it's making it easy for the system to address. And even newer stuff. You know, I've spent time with these folks asking them, well, does it address this? Well, does it address that? So there's some slides in here about the different organisms. Aspergillus, I don't know if y'all have issues out here with that, but that's another one. Influenza, nobody has problems with flu, right? And this was a big testing area for H1N1. The house flies, we love the flies. It does kill flies, by the way. I forgot to mention flies. And then this refers to the total reduction of the environmental pathogens, again, both in the surface and the air. They didn't measure specific organisms. And then last but not least, we are going to have our peer-reviewed publications coming soon to a journal near you. As soon as our data, we do have the systems in at Sunrise, and we're doing our pre-testing now. So I'm very excited. I can't wait.